I want to jump into our morning keynote session here and introduce some of our folks who will be with us. The frame of this conversation is the future of Texas health policy in 2021. That obviously includes the legislative session, but it goes beyond the legislative session. And so we're super excited and honored to introduce our folks here with you today. First, we have Senator Charles Perry, Republican from the Lubbock area. Representative and Dr. Tom Oliverson from Northwest Harris County. Elena Marks, the CEO of the Episcopal Health Foundation, and Andy Keller, President and CEO of the Meadows Mental Health Policy Institute. And Representative Garnett Coleman will join us in progress, but is delayed. But Representative Oliverson, Senator Perry, Elena, Andy, thank you guys for doing this and for making time. Let me start with you, Representative Oliverson. Because you wear both hats as a medical professional, an anesthesiologist, and of course a legislator. How comfortable, confident, excited, depressed do you feel about health policy in 2021 and the legislative session in particular, after having come through a tough 2020, experiencing life in a pandemic? You're now set to take on statutory policy changes. How are you feeling about the topic of health policy in general?
Well, I appreciate the question, DJ, and I feel pretty good about it. I mean, I think last session we had some pretty significant changes, some pretty significant problems that have been festering for a while. I think most notably the issue of surprise medical bills. Not only did we deal with that here in Texas, but Texas actually set a model that essentially ended up, for the most part, being adopted by the federal government. So we really are kind of leading the nation on some of these tough challenges. I think the fundamental underlying problem that has not been addressed, that needs to be addressed, is the ever rising costs per person of accessing the healthcare system, the unaffordability of existing healthcare services, and how that contributes to an inability to access healthcare services. Notice I didn't say the issue is coverage. I don't think the issue is coverage. I think the issue is affordability. And that's something that absolutely has to be addressed in the 2021 session. We've got to bend this cost curve down and make healthcare more affordable across the board, not just for folks who may be uninsured via some expansion project, but really for everyone, because every year we see an increasing number of individuals who are no longer able to afford the coverage that currently exists in the marketplace. So I see that as being the number one challenge. Now, with respect to the pandemic, I think we very clearly saw that we have a number of public health challenges in terms of our ability to respond to an event like coronavirus. Really stretched our public health resources to the limit. And quite frankly, I would say, there was a fair amount of disorganization in the way some of these policies were implemented, despite the best efforts of state health services and the governor's office. We saw a lot of cities and counties trying to go their own way and do their own thing. And, we're going to do this and we don't agree with you on that. And, I think one of the things, just like after Harvey, we had a comprehensive look back and say, kind of what went wrong here? What could we do better? I think we should take this opportunity really to carefully examine the existing public health infrastructure and look for ways to make it a much more seamless, much more efficient mechanism that would allow us to respond in a cohesive fashion as a state to a future pandemic. Yeah.
Senator Perry, Representative Oliverson, as a physician, gets looked to as a leader in the House and in his caucus with 31 senators. You and your role as vice chair and a member of the Health and Human Services Committee over the years, I'm sure your caucus members look to you and say, Senator Perry, or ask, what are we doing on healthcare? What should we expect on health policy in the 2021 session? And when your caucus members ask you that, how do you answer?
Well, first of all, I want to tell my representative and good friend, Dr. Oliverson, we worked on some good stuff last session. We've got a little bit more cleanup to do on those, but it's good to see you. And I appreciate your input over the COVID stuff. You were not AWOL at all. You were front line on a lot of conversations. Most of the stuff that Dr. Oliverson said is absolutely where we're going. Senator Kokorst is chair of HHS, and we've already had conversations actually throughout. And the parallel is after Harvey, she grew up and we supported, and I put out a statewide flood plan. She came up with best practices, right? Things learned and things that we shouldn't do again and things that we should do again, and state response and regulatory reforms that got in the way of being able to handle the COVID stuff. So I fully expect a best practices bill from Senator Kokorst, which we're working through and working on, and specifically state response. We have a disaster team, if you will, ready to deploy in a natural disaster with pretty much ease. What we didn't ever envision as a state is a possible disaster in perpetuity, right, with no clear endpoint in sight, and it goes on and on and on. So that's one thing I think you should expect and will expect, and I'm looking forward to what that piece of legislation will do. Bigger umbrella, obviously, we had some emergency power responses that I think a lot of people didn't understand could happen, and not judging or anything of the decisions that were made. I think those create a lot of angst. You're going to see some focus on what does an emergency powers include and where does the legislature step in. I'm a big believer in the three-legged stool of government, executive, judicial, and legislative. I also am a big believer in 181 minds, hearing from people such as your panelists and other people in the industry groups provide a better solution. With that said, there's always an immediate need to respond quickly and nimbly and go through that process that we need to respect and honor. But the legislature has to, at some point, have an active role or voice to that. Because in my district alone, 51 counties, I got it all, right? Rural, urban, no access to health care, no access to broadband, public education, 160 school districts. I get it all. And the challenges that came through those processes are real. I tell people when urban suffered, then rural benefits. And I think urban's internet debacle or void was finally highlighted to the point that rural broadband is going to absolutely happen this session. Majority of reason why is because the federal dollars have committed up to $9 billion of actual broadband monies to put rural in connect. So, and actually working on that very diligently on this side, and I know the House's side, there'll be a rural broadband bill that addresses that void, and it will bring telehealth and teledentistry and telepsychiatry and all of those things into fruition that we've all talked about for years. It's going to be a reality this session. I had a great meeting yesterday on how that could look. I think that you're going to see a lot of COVID discussion around what it revealed. Number one, it revealed the fragility of human nature, right, in our physical existence. We are vulnerable. It revealed a lack of faith or perpetuity into an eternal perspective. A lot of people don't have that set. So as a faith person, we have a lot of work to do. I think the Great Commission is alive and well through COVIDs, and it highlights. It also highlighted the worst and the best of Texans. We had a lot of folks step up and do, as always in these events, do what they were asked to do or needed to do without being asked to. But we also had a lot of people that took advantage, I think. So COVID was one of those things we don't want to go through again, but we will survive it. We will be better from it. Rural access care was a big thing last session. Senate Bill 170, bring Medicaid cost reimbursement into a statutory and not a rule. We are currently in an appropriation cycle that is projected to be about the same number we had last session. So that dispels the narrative that we're broke and we can't fix anything. That's just not true. We got resources to deal with it. Comparatively speaking to 2011, we are way ahead of the game on the budget cycle. Telemedicine and those things, vaccines finally moving. I think that's just going to get better. So the momentum for budget purposes is really there. I would say that we've got some cleanup work to do from where we had last session, excluding the COVID issues. COVID cannot be the agent of change for long-term plans. It needs to be a bump in the road that we look past, get past it, and be better. And when I say that, that's something as simple as our transportation budget, right? We've got 20-year visions. We can't let COVID be the roadblock to not implementing those. So my word for the session regarding budgets and other things is don't shipwreck our plans. Mental health, we've got billions of dollars going to mental health initiatives. We probably learned more than ever, and this is not true just with mental health. We are a relationship-driven people. We want human contact. We need human contact. And we want to be able to trust those individuals that we have contact with. If you're going to change a heart or a mind, you need to be personally invested and have the time to invest in those individuals, and you'll have the results you seek. I think COVID, more than anything, highlighted that when you don't have that reach, as hard as we can try and as much money as we can spend, it's not going to have the outcomes that we hoped. So, and that's a biblical model that's been set out years, thousands of years ago. People need to have people. So COVID reinforced that, and that's a good thing. Sometimes we need a reminder that it's about the people and the time invested. So I could go on forever. The 1115 waiver was probably the biggest unknown that we now know. 10-year extension. I know we get a bad rap sometimes as a state. Here's the challenge, and my colleagues that support expansion or doesn't, arguably we need to find a better method for sure, but finding a way to help the working class poor without creating another working class poor to pay for it is the challenge. And secondly, we don't want to enable those that could work, that could become part of the working class poor with opportunity to move out of that into a system that's mediocrity, race to the bottom, and encourages status quo, because there's just so much other things that are joyful, the self-esteem and work and things that come with it. So that is the balance we try to strike, and we haven't done, I don't think, as a nation or as states or as communities, we haven't found that balance yet. So I agree with Representative, the cost is big, but those are the challenges we face, I think, and there's some of them the same challenges for next session.
There's a lot baked into those comments. That's a lot, Senator. I appreciate it. Elena, let me ask you to speak to one piece that he touched on, which is what we have learned from this COVID pandemic. Episcopal Health Foundation puts a lot of time and energy into research and data. What do you think policymakers should know about what we have learned as a result of COVID that can better inform policymaking in this session?
A couple of things. First, I appreciate that you both mentioned the public health infrastructure. We don't have the public health infrastructure that we need. It's not unique to Texas. It's an American phenomenon. And I look forward to seeing a bigger investment in the public health infrastructure, because the way you stop or prevent things like pandemics is through public health, not through health care. And so our underinvestment in data systems and personnel and training has come home to roost. And so I really look forward to the momentum for rebuilding our public health infrastructure. The other thing we have seen is the fragility of our healthcare delivery system and the growing number of uninsured. And you both mentioned the problem of access to care. And Dr. Oliverson, you mentioned it in terms of it's not coverage, it's affordability and access. Coverage is the means to affordable access, and it is the best one we have. And I wish there were other tools available, but we do have the opportunity to build a Texas program and draw down 90 to 1 to 10 federal dollars in a way that meets our own unique needs, as many other states have done that have conservative leadership and the same values that we have in Texas. And we have new data courtesy of Texas 2036, who's done an amazing job of showing what the costs and benefits are to a 90-10 coverage expansion. And if we can do this affordably, I guess I would ask, why would we not do it? Why would we not allow people to have health insurance coverage if we can do so affordably? Because that's the mechanism that we're all using. None of us is giving up our health insurance saying we just want to pay for more affordable prices. So I really hope that legislators will take a pragmatic look rather than and look at the costs and benefits. There are studies out from the states who have been in this for a really long time, and both the financial benefits are clear and the health benefits to the population. I'm going to stop there, but happy to continue this conversation and provide data that I hope legislators would look to in making decisions about what the options are. And if there's something better than a coverage option, I haven't heard it.
So Andy, let me ask you to follow up on Elena's comments, but particularly related to mental health. I mean, she's talking about Medicaid expansion and extending benefits, but as you are thinking about the mental health of Texans, particularly as a result of COVID, something exacerbating issues that have already been in place, what do you think we have learned from this year in COVID that should inform policymakers in the 21 session?
Yeah, thanks. And I think, some of the earlier comments, particularly from Senator Perry, I think say this. So I think we've all learned two things about mental health under COVID. One is that mental health is a physical condition. Mental health is something that we can feel physically. 4 times as many Americans today are, and that includes Texans, are reporting symptoms of depression, symptoms of anxiety than they were a year ago before COVID. Well, a little bit more than a year ago because we were kind of getting into COVID about a year ago. So we know that, and we know that viscerally. And I think it's relationships, like Senator Perry said, but it's also the uncertainty, the fear. And so we have those conditions. And I also really appreciated Senator Perry too about we can't just be reactive. We can't just say, let's deal with COVID. We have to look at the underlying trends. And unfortunately, the underlying trend on mental health, while Texas is doing more than ever, and I commend both Dr. Oliverson and Senator Perry and our state leaders for all the investments over the last several sessions. As Americans, we have not yet turned the tide on the terrible epidemic that predated this pandemic of suicide. We had a bit of a pause among some populations in 2019 of the escalating rates, but we know that it's increasing under COVID. And the terrible thing is we know what to do about it. It's the same thing we do for every other disease, is we don't wait 8 to 10 years like we currently do to provide treatment and wait till people are in state hospitals and homeless and dying from suicide. We identify the illness early. So I sit on the National Response Steering Committee for that Josh Gordon, head of the NIMH, and Patrick Kennedy lead nationally. The solutions that we have endorsed begin with primary care and begin with finding and detecting mental illness and particularly depression as soon as it emerges so we can help somebody before they become suicidal, just like we do with heart disease, just like we do with cancer, just like we do with COVID. Detection of COVID, aggressive treatment early with COVID is exactly what we're doing to get ahead of it medically. We need to do the same thing with mental health, and we have an opportunity to do that by adding collaborative care, a primary care-based intervention to our Medicaid program. The second thing we learned is that there is a relationship between our mental health and the rest of our body. I like to call it the below the neck health and the above the neck health. And that relationship, look at COVID. COVID is increasing mental illness rates by 6% based on a study in The Lancet 2 months ago. But what is more terrible is that people with mental illness are 65% more likely to get COVID. People with mental illness are at higher risk. And that's how this works. Mental illness is a bad thing, but it puts us at higher risk if we have a mental illness of deep physical illnesses. And that's why Elena's points about coverage are so important. We had wonderful advancements through the 1115 waiver to both shore up some things, but also to shore up our mental health care. What we don't, unfortunately, have is anything beyond local taxpayer-driven health systems for uninsured Texans, adults with mental illness for the physical health needs that are exacerbated by mental illness and are making us, if we have a mental illness, die at age 49 on average of COPD, hypertension, metabolic-related conditions. That's the real impact of mental illness, is on the below the neck part of our body, and we need to do more there.
So, Dr. Oliverson, let me ask you, how do you sort of navigate these political polls. I don't know if that's quite the right word, but on the one hand, you've got the speaker saying that there aren't votes for Medicaid expansion, and on the other hand, you've got maybe a more granular conversation, maybe not as sweeping, more granular in that rates of anxiety are up, rates of depression are up, rates of suicide are up. And there is a need to do things like support Texans' mental health in a better way. So how do you sort of square this circle and make it through the next 5 months in terms of health policy when you've got these real world consequences and then this conversation about solutions that may not have the votes? What do you think?
Well, I think that, again, this is not a one size fits all. There's not one solution to the problem. So I think what you begin by doing is looking for solutions to the problem that you can achieve, that have a fairly immediate impact, that are achievable. One of the things that Senator Perry and I have been very aggressively working on for the last several sessions is an expansion of telehealth services, and particularly as relates to our conversation about mental health, the ability to further utilize the existing mental health resources that we have by using telehealth services has been pretty profound. In fact, I actually read somewhere that, now that telehealth is becoming more accepted for mental health services, that, patient satisfaction scores are actually going up compared to in-person visits. And so we need to do whatever we can to encourage more of that, a larger embrace of that model by existing healthcare providers. But also, I think, and we'll come back to a conversation we had several years ago that I know the senator and I have talked about before, which is, we need to look beyond our borders when we start thinking about some of these, health provider pools where we have existing shortages, and there are providers in other areas, states that are like-minded to Texas, that have a similar pathway to licensing and accreditation, same values. And we need to find ways to allow them to be able to lend telehealth services to augment the existing pool of providers we have here. So I think, that's a good example of something that can and should be done and will be done.
I want to just,
right?
I'm sorry to interrupt you. Sorry,
go ahead.
No, I'm sorry to interrupt. I thought you were finished.
No, that's fine. So, I just throw that out there as an example. I strongly believe, and I see this as somebody on the inside, nothing we have done in the last 40 years in healthcare has actually done a whole heck of a lot to really bend the cost curve down. When you talk about expansion of this government product versus that government product as your only means of controlling prices, basically what you're talking about doing is moving to a single payer healthcare system over time, where government essentially fixes the prices for goods and services. Well, that is not working too well, has not worked too well. And given the fact that about 50% of physicians in Texas will even accept new Medicaid patients, that's not a good benchmark for further coverage. If we're going to talk about coverage expansions, relying on a system that only half of primary care providers are willing to take new patients. And let's be honest, that the reason for that is quite simple. The reason is that the red tape and the requirements to participate are so onerous in comparison to the reimbursement that physicians opt out of that system literally as soon as they can, for the most part, and other providers as well. It's just not a valuable thing for them. And I see this in my own practice as well, in anesthesia land. It's just, we need a better solution. That's just not a good solution, in my opinion. And, happy to have that conversation as well. But it also doesn't really do a whole heck of a lot to address the fundamental underlying problem of our healthcare system, which is that, unlike any other sector of the economy, I can't find out what something's going to cost me, even if it's a shoppable service, until 30 days after I've purchased it. Imagine if you were buying a car and I told you couldn't know what the price of the car was going to be until you were driving it for a month. And then I would send you a bill in the mail and you were obligated to pay that. I mean, that's ridiculous. We can and should do better. And quite frankly, looking at this from a conservative worldview, the free market and free market forces, if we would just allow them to have more influence over our healthcare economy, would do a great deal, I think, to lower the cost. I've never, as a physician, I've never really felt like it was the only way to provide primary care was by coverage. It seems to me that there should be a system to where routine primary care could be affordable enough that people don't actually have to have insurance just to be able to afford it. I mean, I think that's kind of silly. Yes, there's always going to be a need for coverage. There's always going to be a need for insurance because some things are not shoppable. Some things hit you out of the blue. You know, sometimes you go to the doctor, they feel a lump, and the next thing you know, you have breast cancer. There should be coverage for things like that. But if you're just talking about routine primary care, I don't know that coverage is really the best model for controlling costs for things like that. I look to models like direct primary care as a promising thing in the future, where we actually have patients and physicians entering into these agreements in advance, and the patients are much happier and the doctors are much happier, and the costs are much lower.
I want to make sure that our audience members that you all know that you can pose questions in the chat box, and I'll try to integrate those in the last portion of this. Senator Perry, let me go back to something you said and that Representative Oliverson and Elena and Andy have all been sort of speaking to in their comments, which is the comment that you said that we need to be doing, I think, need to be doing better than the current model vis-a-vis the DSRIP funding, the waiver funding that comes into hospitals, recognizing that is likely going away under our current waiver. What are you hearing? Like, what are if it's not the coverage extension and expansion model, what are some other options that you hear about that might help improve that safety net funding model that comes through the waiver now, but which is going to be timed out?
Yeah, so I haven't studied the 1115 new waiver. As some of the meetings I've had on it, there are some really positive moves. I think people think we just had one and we renewed it as is. Actually, there was some flexibility in the new waiver that we're currently talking about. I don't know that it's been completely settled that it is, but as an example, our rural healthcare outpatient, inpatient rates, right? And we did 170 last session to help fix some of their woes. Under the new waiver, what we believe to be true and what we have asked for and received, they will have the flexibility from moving between out and inpatient services. So, you know, it's one of those deals, you pay me $100 million for something I only needed 60, but you shorted me $40 million on the outpatient side or the inpatient side, and vice versa. And they're going to have the flexibility to move with payments within. So in a perspective, it's kind of a block grant on certain aspects from what I'm hearing and understanding. So it's moving it in the right direction to where you don't pigeonhole dollars that may have not been needed. You know, it gives the control to the patient and the doctor or the facility out in those areas to be flexible and meet the needs. So secondly, my congressman out of this area supported bipartisan out of DC to remove some of the huge fixed cost barriers to rural healthcare clinics, the staffing ratios, the equipment, all of those things that obviously you want to have access to during an emergency, but he's moved them to more of an emergency look, right? But not requiring a staff ratio that's untenable because there's not enough personnel to meet it to start with, and removes them from a classification that denies them additional funding. So we have got an overall partnership, federal to state, that recognize rural healthcare is different. Outside of rural healthcare, I'll go back to, we all want people to have access to care. There's not a politician on either side of the aisle that doesn't. Secondly, we want those that are working class that need that access to be affordable by virtue of, as Representative Oliverson, I've got 2 doors. I can be within walking distance of 2 primary care physicians that I can literally walk in, no insurance, and for $60, and that's a lot of money to a working class poor, I'm not diminishing that, can actually get their care needs met. So I think we're on the right track. And I think the new generation, the younger generation, my kids at 30-somethings, are real comfortable in the internet world. They like to go on healthcare and not leave their couch and say, here's what my symptoms are, what do you think? So free market evolution, new generations of what they expect from their healthcare system will drive, I think, more innovation and make those costs come down. As far as the actual Medicaid expansion topic goes, I agree 100% with Representative Alderson. We do not, and Medicare for all is a big discussion. It actually works pretty well, right? And it works pretty well because it's uniform. We have 50 Medicaid systems around this country that require 50 individual bureaucracies with 50 different innovations and waivers and stuff granted. So I'm not advocating Medicaid for all or Medicare for all, but I don't disagree that there's probably about 30% of the Medicaid system that if there could be some uniformity, and that may mean giving more flexibility, right? And that's where Texas has been, to where they don't have to have the bureaucracy to maintain those dollars, because that's a lot of a waste and inefficiency. So we'll keep pushing for those changes. I want our doctors, I will say, back up a little bit. Some of the measures took during COVID, restricting doctors to do what doctors do best, is one of my priority items. I don't believe there's, quote, elective surgery other than basic cosmetics. I don't believe my doctors do procedures because they're just procedure happy and don't have anything else to do. I still think the long-term impact of some of those decisions are going to be felt for years to come. So I want the doctor to be in control. If the doctor can do a quality job for $2 less, that consumer needs to be able to have his option. So we're going to keep doing those things that we do. I can't add 1 million people in Texas to the rolls, to a system that's already broke and $30 trillion in debt at the federal level to fund it, and expect the outcomes to be good long term. Those are irresponsible conversations, and we just need to get off of that and find what we've got. These are the rules of the day, and make them work the most efficient way to meet the objectives.
Elena, I want to come to you and switch gears just a little bit to the adjacent topic of racism, and the social inequities and health disparities that we've seen come out of COVID. These, of course, are not new issues, but COVID has exacerbated these, and the data is pretty compelling. What have you learned? What have you seen during this COVID pandemic about health inequity and how outcomes vary widely and dramatically across race?
Well, exactly that, and it's not surprising. The people who were most likely to get COVID in the first place were the people who were in jobs and living situations that exposed them to it. I get to work from home. If you're an essential worker, if you're working construction or in a grocery store, you had to go to work. You probably didn't get paid time off. You may live in a crowded household where you can't isolate from others who may be ill or when you're ill. And so they were set up to be more vulnerable in the first place. On top of that, they were more likely to be extra sick, requiring hospitalization or to die, largely because of pre-existing conditions that are the product of not health care, but the environments in which they live, the so-called social determinants of health. If you already are obese or have hypertension or other pre-existing conditions, if you contract COVID, you are more likely to have severe adverse outcomes, including death. And what we saw play out in COVID, not just in Texas, but across the country, is that those populations are disproportionately poor and disproportionately people of color. And in Texas, it's very concerning because that's a significant percentage of our population. And some of the data that we've seen has shown that if Black and Hispanic Texans had the same outcomes from COVID as white Texans, we would have had way fewer hospitalizations, we'd have had fewer deaths. And so to me, what COVID has exposed is what was already there before, that the people who were most disadvantaged were going to be hit hardest by this pandemic, just as they are when we have hurricane. In Houston, we always have hurricanes. Those are the same populations that are adversely impacted. And so if we really want to improve our state averages, which are low in a lot of health outcome categories, our best bet for doing that is going where there's the most opportunity for improvement, and that would be within the minority populations. And we can do that through Medicaid. We can do that with Medicaid embracing social determinants of health, which they're starting to do. We can do that with a more holistic approach by the legislature, because you ultimately own it all, whether it shows up with low achievements in education or too much dependence on public support for housing. If we can improve the overall health and life trajectory of the populations who have the worst outcomes right now, while it's long-term work, in the future, it benefits not just them, but it benefits all of us, because we will have more productive, self-sufficient citizens and family members and communities. And we can do that.
We just have just a minute or two left here. I want to make sure all of our attendees have an opportunity to bounce around and do other things before the top of the hour. But Andy, I want to ask you this last question, building on what Senator Perry said, and really the entirety of this conversation. Given DSRIP and the waiver and the needs of Texas and the new federal administration, the new Biden administration, what opportunities do you think there are for Texas policymakers to be thinking about federal engagement and the state-federal relationship in a different way because of this administration? Are there areas of opportunity that you want to highlight now that we have gone through or making our way through the transition?
Yeah, I mean, I think that, the main thing we need to do is come together on the COVID impacts for mental health. I mean, that's the main thing. And suicide is the main risk. And it's going to unfold over the next couple of years. And I think the national consensus that Josh Gordon from NIMH has forged around this with the national response to COVID is something that I hope the new administration embraces. There's signs that they will, but it's also something that I think has buy-in at the state level, because it comes back to what Dr. Oliverson was saying earlier. Primary care is the key. And this is also to what Elena was saying, like early access is the key. We have to treat mental illness in primary care, and we have to give the supports like we did last session through the Texas Child Mental Health Care Consortium to pediatric primary care providers. We need to build on that, and really the tools are there, and we can probably save 1,000 Texans a year if that national consensus moves forward and we're part of it.
1,000 Texans a year, those are real numbers. I know we're near the end. We have just a few minutes. I'm wondering if you all could give a short answer to this, or we'll run out of time. What are you most hopeful for, each of you, as you look to 2021? What gives you reason to smile and be hopeful? Representative Oliverson, I'll ask you first.
Well, DG, I think the thing I'm most hopeful about is the fact that we're going to make healthcare more accessible and more affordable by the end of this session. I mean, I really think that's within our grasp. I think we've talked about a few things today that will help us get there. I also want to acknowledge something that Elena said. As a physician legislator, I strongly believe that there are social determinants of health, and that they contribute mightily, not just to a particular group's mental, but also physical health, and that needs to be addressed. I was touring the new Dell Medical School, and I was very relieved to see that they are light years ahead of where I was as a medical student in the 90s, as far as embracing the idea that, there are social determinants, there are genetic determinants, but with diversity in our population, it's important to remember that we need a diverse healthcare workforce that's capable of really sort of analyzing not just the physical health, not just the mental health, but also the social fabric in which the patient resides, because, that has a lot to do with it. And so I think we really need that more holistic approach to making a healthier Texas.
Elena, one thing that gives you hope for 2021?
What he said. The fact that the legislature, and particularly specialty doctors, are recognizing recognizing that the social determinants are actually more influential over our health than medical care gives me great hope, because I think we have a lot of opportunity to really improve the circumstances of people's lives and not rely on, as Andy said, state mental health institutions and people dying from COVID in the hospital on a ventilator because they don't live in circumstances that allow them to live a healthy life. So
Yeah.
that's what excites me.
Good. Andy, what gives you hope?
Making these telehealth waivers permanent. Audio only telehealth for mental health is, I mean, we need broadband, but like everybody's got a phone and it works for lots and lots of things. So make those waivers permanent and I'll have a happy 2021.
Senator, what gives you hope as you look ahead to 2021?
Well, 181 good people trying to solve big problems is always a joy to get back to. I missed them over the interim. I call people, we're kind of like a circus, man. We're a little bit carny-esque. We each have a mission. We go hawk it, but we are good to be in Texas. I'm excited about it. I tell you what COVID did for me personally, and it sounds a little bit probably cliche. We recognize that liberty can be lost really fast. Would we let government do too much? And I think you're going to see a resurgence of trying to keep that in a balance that maybe we've lost over the years. So I'm excited about reaffirming that. I would tell you the social environment, I hear a lot about the minority groups, and absolutely they've been impacted. Those same issues, access to rural healthcare, access to education, access to physicians, are all rural issues too. So it's not a racial as much as it is just logistically where you choose to reside or can reside. Secondly, the human condition / behavior. As much as we try to fix people's problems, there has to be a behavioral shift and change. And so I'm very cognizant that we should do everything we can, but at some point it does lie at the footsteps of the independent person to make those independent decisions to want to change. And that's the biggest challenge to our social deal. But I'm excited to work with good people like your groups and Representative Alderson and Coleman. I love Coleman. All D's and R's still work for the things that really impact our everyday citizen well together. That's a challenge in today's politics, to be perfectly frank, because there are dividing issues, and we're going to have those conversations. But on the issues that the overall public can benefit or help from, we are still committed to that. Thank you guys for having me on. I've got to get to the next Zoom meeting. Redistricting started at 9.
Yeah.
That's just the other little bill we're working on this session. So you guys appreciate it. Y'all have a good day.
Thanks, Senator Perry. And Representative Alderson, thank you. And Elena Marks, CEO and President of the Episcopal Health Foundation, and Andy Keller, President and CEO of Meadows Mental Health Policy Institute.